Pancreas and Metabolism Part 2, Body Weight Control. In this video, we'll introduce a couple of these concepts. We're going to explain how body weight is regulated. We're going to describe the role of leptin in fat tissue. We're going to explain the concepts of being overweight and being obese. And we'll describe some of the implications for physical therapists and our practice. Concepts on body weight regulation. We know that energy that is in excess in the body is stored through fat. And there's a lot of genetic variance as to where and how much that fat is stored and where is it accumulated in the human body. We also know that as we go up and down in terms of weight, there's two different changes within fat tissue. A change in the shape and form, mostly their size, and also the number of fat cells. Fat cells are called adipocytes. So the two determinants for caloric intake, very straightforward, is determined by both appetite and whatever food is available at the moment. There are agents that promote or discourage the intake of food. The ones that facilitate or promote appetite are called orexigenic versus anorexic agents, which suppress appetite. Now, in terms of weight gain and weight loss, to put it very simply, weight gain is observed whenever the calorie intake is higher than the energy expenditure. Weight loss is the opposite, whenever the energy expenditure exceeds the caloric intake. So how is energy expenditure regulated? From autonomic nervous system stimulation, also under hormonal control, which we're interested, but most definitely as part of our practice with physical activity. On this slide, you can appreciate two adipocytes and how the content of the fat reservoir changes the size and the shape of this cell. And this is a micrograph of how these cells look like in standard histological preparation. But the part of the slide that I'm more interested in showing you is the bottom part. So here on the left, we have a never obese fat cluster of cells, and notice how in an obese person both the number of cells and the size of those cells are large. If that person loses weight, the size of these cells diminish, but the number of cells does not. One of the ways that we can use in order to get an indirect measure of fat content is through body mass index. This is an index that takes in consideration the patient's height and weight. The range that is considered to be normal or ideal is a BMI that falls between 18.5 and 25. Under 18.5 is considered underweight. Overweight is from 25 to 30, and then there's 3 grades for obese, depending on where in these ranges your patient falls into. These values were taken from the American Medical Association. However, BMI values do not take into account the increase in weight of muscular tissue, for example. In this slide, you can see how a person that weighs 250 pounds can be can have very different body compositions. In this case, anthropometric measurements such as waist size is probably a better determinant for prognosis and other factors. Leptin is a chemical compound that is synthesized and released from adipose tissue. After an excessive storage of fat, these cells are going to increase in number and in size, and that promotes leptin levels to be increased in the bloodstream. The hypothalamus is sensitive to changes in concentration of leptin. Leptin concentrations change proportional to fat storages in adipose tissue. What this promotes, or the rise of leptin, what it does is a reaction from the hypothalamus, which will promote food intake to be decreased, expenditure of energy to go up, sometimes in the form of thermogenesis, and an increase in sympathetic activity to try to literally burn it out. Now, if the opposite happens and weight loss is observed, then leptin levels in blood are going to drop. that also triggers the hypothalamus to do other things. For example, to increase our appetite. So food intake may go up. The hypothalamus will then facilitate the regulation of temperature, keeping it down, as well as other energy expenditures. Reproduction functions are down, and parasympathetic activity rises as a response. We definitely need to consider the overweight and obese population. We're going to see a high incidence of these patients in our clinical practice. In the United States alone, 149 million people are overweight. Another 75 million people are obese. And 1 in every 3 children are either overweight or obese. The differences are stated here on this table. We're going to go over these factors in class, but know for now that there is definitely a difference in BMI or body mass index, and you're going to see a lot of risk factors and causes that are going to be repeated. Now we know then that in overweight and obese people, the levels of leptin in blood could be as high as 4 times the normal amounts. So we can say that it's a leptin deficiency that's causing being overweight and obese. There's also very rare, very uncommon problems with leptin receptors in the hypothalamus. So what is it then that's causing this drive? It has been proposed that it's then something called leptin resistance, where the defect is more on the target tissues and their second messenger systems, rarely in the hypothalamus. Leptin resistance has been found to be correlated with upper body obesity, also insulin resistance, hypertension, abnormally high concentration of triglycerides in blood, and usually the treatment that we go to is diet, physical activity, leptin therapy, which is hormonal therapy, and bariatric surgery. Now let's go ahead and review some of the pathologies of this endocrine gland. Type 1, the risk factors for diabetes would be family history, first sibling or parent. For type 2, it's a little more of an extensive list, including positive family history, ethnic origin or non-Caucasians, obesity, like we talked about, older than 45 or middle age, leading a sedentary life, having a previous history of gestational diabetes in women, history of vascular disease, hypertension, high levels of cholesterol, and smoking cigarettes. Let's take a look at some of the pathophysiological effects we can see in these patients with diabetes. The first one is macrovascular damage, specifically the buildup of plaques known as atherosclerosis. Here you have a cross-section of an artery and the wall. You can see here the formation of plaque. This plaque is a clump or cluster of multiple things, including lipids and calcium, some cells, smooth muscle cells, and some macrophages. And these buildup will narrow and decrease the diameter or the lumen of these vessels. Changes in blood vessels can impact many different places. Here is a diagram illustrating those vascular changes in the arteries that provide nutrition for the retina. This complication in diabetes is called diabetic retinopathy, and it has an impact on visual field perception. Problems with vascularity also have an impact on peripheral nerves, specifically the distal ends of those. As vascular supply decreases, so does the myelin, interneurons, and potential axons in those cells that do not receive enough supply of nutrients and oxygen. Some of the cardinal signs of diabetes, both type and 2, and for more detail, just read in parentheses, polyuria, polydipsia, and polyphagia, which we have seen before, weight loss, recurrent blurred vision, ketonuria, paresis of muscles, obviously, and it could also be asymptomatic for a period of time. Now, this slide lists some of the clinical signs that we would most likely be able to see in our patients. Retinopathy, changes in their visual field, neuropathy, changes in their peripheral nerves, especially in the lower extremity, and nephropathy, changes in kidney function. Infections, so if the patient has an open wound especially distally in any of the extremities, it slows down the wound healing process. And it can also be associated with hypoxia, decreased oxygen. Carpal tunnel syndrome is also a common finding. Contractures in the palmar aponeurosis, changes in the length of tendons causing trigger finger. Diabetic patients are, their incidence of adhesive capsulitis is much higher than the rest of the population. They can also present with something called stiff hand syndrome, flexor tenosynovitis. So a couple of these are inflammatory processes. Definitely a very common complication is complex regional pain syndrome, also known as reflex sympathetic dystrophy syndrome, in which we see differences in upper and lower extremities in terms of girth, but this is not necessarily related to peripheral edema. And finally, bone spurs. On this slide, we have more clinical signs that we may see. Sensory polyneuropathies, especially hands and feet. We may see some foot drop, associated again with an increased risk of falls, mostly because of muscle paresis and peripheral nerve damage. Diabetic peripheral neuropathic pain, that usually happens at nighttime, and it's an abnormal perception of pain stimulation. Secondary problems that could be trauma or falls, Charcot's, and a couple of bone deformations, like the one illustrated here, like in the bottom of the foot, some displacement of tarsal bones. Most commonly affected joints are the MTPs and the TMTs as well. This last slide lists some common PT interventions for people with diabetes. We already know how much exercise can impact potentially the uptake of glucose in multiple tissues in our bodies. And this obviously is also true for people with diabetes. We would most likely be involved in wound care. A lot of type 1 diabetic patients will end up having amputations, most commonly lower extremity amputations. So we will have to not only care for wounds in this population, but also assist in strengthening range of motion and gait for them. Total contact casts for some ulcers, again, some complications with the integumentary system. We'll have to be careful and specific using evidence-based parameters for therapeutic exercises. If at all applicable, we need to monitor glucose every 30 minutes, even if the patient is asymptomatic. And this is obviously very different according to facility and depending if you're in an inpatient or an outpatient setting. Include flexibility, muscle strengthening, range of motion, and endurance, gait training, balance, and prevention of falls. Definitely patient education for the diabetic feet. And you must stop exercising with your patient if they're at peak of insulin and if their glucose level is over 250 milligrams per deciliter with ketosis.